Yeah, so for CAR T, I mean, I think as of right now, we have brexucabtagene. That has been sort of the mainstay for the last several years after the pivotal study by Dr. Michael Wong. So we know that agent is efficacious. The downside to brexucabtagene, unfortunately, I would say, is the high incidence of grade 3 to 4 ICANS, the immune cell associated neurological syndrome. Because of that, I think there is some hesitancy in some situations about this agent. Just because, again, that complication is there, and ICANS sometimes can be very difficult and very problematic for patients and their families to see these patients go through that. If we take that aside, though, I don't think there's any arguments about efficacy. The duration of response is something that we're still trying to get a good grasp on, because with subsequent updates, we've seen more and more patients relapsing with this treatment, so I don't think it's going to be curative, similar to what we see in diffuse large B-cell lymphoma. On the brighter note, liso-cel recently reported out some new information about their CAR T product, which is a 4-1BB stimulator versus a CD28 with brexucabtagene. And the good news is, efficacy-wise, it appears very similar, and safety-wise, it appears that they have significantly less ICANS. So whereas like around 30% with brexucabtagene, the grade 3-4 ICANS with liso-cel was reported at 9%, which is a significant reduction. Unfortunately, we still don't have access to that in mantle cell lymphoma, so we're still at this point with brexucabtagene or any clinical trials that may be looking at any sort of novel CAR T agents. But hopefully in the upcoming year that liso-cel will get an indication in mantle cell, or depending on how the FDA plays it out, we may have to have another phase 3 trial with that drug.